Hi guys, good morning. Can you all see my screen and can you hear me? Right. Okay, so in our last class we had discussed till the GI tract. We will take it from there. Today we will start with the various organs. And at the end, we will discuss the questions. So let us start with the liver. So as you all know, liver is the largest intra-abdominal organ in the body. Can you tell me what is the largest organ of the body? Largest organ in the body? Yes, right, skin. So the largest intra-abdominal organ is the liver. Okay. So the liver, as you might remember from your anatomy classes, there are two lobes divided by the falciform ligament into the right and the left lobes. Okay. But the story does not end here. Okay. From a functional aspect of view, from a surgical point of view, we need to learn a little bit more. What is that? So, uh, the hepatic veins, how they divide the liver is of utmost important functionally as well as surgically. So there are three hepatic veins: the right, the middle hepatic vein, this one, and the left hepatic vein. Okay, so these three hepatic veins divide the liver into four sections. Okay, one, two, three, and four. Okay, so you see the right hepatic vein divides the right lobe into a right posterior and a right anterior section. Okay. Then the middle hepatic vein divides the liver per se into the two broad right and left lobes. Okay. The middle hepatic vein, this one. Now the left lobe is further divided into medial and lateral sections by the left hepatic vein. Okay, I'll repeat. So the liver is here per se. The middle hepatic vein divides the liver into the grossly right and left halves. The right half is divided by the right hepatic vein into two sections, right posterior and right anterior section. And the left hepatic vein divides the left half of the liver into a medial and lateral section. So you have got four sections: right posterior, right anterior, and left medial, left lateral. Now, the portal vein, this one, the portal vein is coming like this, dividing like this horizontally. So this plane divides the liver now into eight segments, as you can see in the numbering. So four sections by the hepatic veins, subsequently into eight segments by the portal vein. What are the segments? So in the left, we have the segments 2, 3, 4. Segment 1 is a segment by itself known as the caudate lobe. And on this side, segment 5, 6, 7, 8. Okay. So we have total of 8 segments, 4 sections divided by various structures. So anatomically, you would have read in your anatomy books, right and left lobe simply by the falciform ligament. Life was simple that time. Now you have to know a little bit more, which is the functional division into four sections, eight segments by the various veins. Okay. Now there is one line called the Cantley's line. Cantley's line corresponds to the line in the plane of the middle hepatic vein. This one, it is a line joining the IVC and the fossa for gallbladder. So this line is the Cantley's line. This Cantley's line divides the liver into right and left functional halves, whereas the falciform ligament divides into anatomical halves. But when you see the liver grossly, you see the falciform ligament going in between the smaller left lobe, larger right lobe. Simply you say this is the smaller left lobe, right lobe divided by the falciform ligament. But once you delve a little deeper, you see things are a little more complicated. So the falciform ligament is in this plane dividing into this left lobe and the bigger right lobe. So according to falciform ligament, there will be only segments 2 and 3 in the left lobe. But as per the Cantley's line, there are segments 2, 3, 4 in the left lobe, 5, 6, 7, 8 in the right lobe. The first lobe, the segment 1, doesn't come into any of these actually. It has its own blood supply, venous drainage, and the biliary drainage, caudate lobe. Is this slide clear to everyone? Right. Okay. So, in very simple terms, anatomically, once you see the liver, you see the liver with a falciform ligament somewhere in this region. So, you can simply say, based on the falciform ligament, this is the left lobe and this is the right lobe. Okay. But actually, functionally, the liver is divided by something known as the Cantley's line into right and left lobes. The Cantley's line corresponds to the plane of the middle hepatic vein. This plane, okay, this one. So if you divide the liver into two parts by the Cantley's line, now you have a right and a left lobe once again. So this right and this left lobe is further divided into the corresponding right and left hepatic veins. The right lobe is divided by the right hepatic vein into a right anterior and a right posterior section. The left lobe into a left medial and left lateral section by the left hepatic vein. And then the portal vein comes transversely and divides these into further 8 segments. Segments 2, 3, 4 in the left lobe, 5, 6, 7, 8 in the right lobe, and segment 1, the caudate lobe. Okay. So the Cantley's line, a line joining the IVC and the gallbladder corresponding to the plane of the middle hepatic vein, divides the liver functionally into a right and left lobe, which contains segments 2, 3, 4 on the left side, 5, 6, 7, 8 on the right side. Period. Done. And the falciform ligament divides the liver into a simpler left and right lobe. In this left and right lobe, you have only segments 2 and 3 in the left lobe and 4, 5, 6, 7, 8 in the right lobe. Take a moment to absorb this. Anyone else? Any questions? Okay, so I will continue. Now, this photograph, you are seeing the liver from its undersurface. Okay, so imagine the liver is like this. Now you have just turned it like this. The undersurface of the liver, this surface is now facing you. So this will be the right side. This will be the left side. This is the falciform ligament. This is the IVC. This is the IVC. This is the gallbladder. So this will be the Cantley's line. So the falciform ligament divides into the old left and right lobe, the new left and right lobe by the Cantley's line. Here you have, this is the quadrate lobe, this is the caudate lobe, the segment 1, and this is known as the porta hepatis. Okay, entry to the liver. Portal means a gateway. Okay, hepatis means liver. So three structures entered the liver. What are the three structures? The hepatic, the portal vein, the hepatic artery proper, and the common bile duct. Okay, there are three structures present in this gateway. Of these, the portal vein and the hepatic artery, they take blood into the liver. The common bile duct, actually, it is the common hepatic duct, not the bile duct per se, it is the common hepatic duct. They leave the liver. This leaves the liver, and these two enter the liver. Okay. Now, this arrangement is very important. Okay. So, as you understand, I will say this is the posterior aspect, this is the anterior aspect. The gallbladder lies anteriorly, I will say posteriorly. So, if you look at this arrangement clearly, and you correspond this with this schematic diagram, so you see the portal vein will lie behind posteriorly. Okay. Anteriorly, you have the common hepatic duct and the hepatic artery. Duct on the right side, hepatic artery on the left side. So the arrangement of structures at the porta hepatis is like this. Posteriorly, you have the portal vein. Anteriorly, on the right side, you have the common hepatic duct. Anteriorly, on the left side, you have the hepatic artery. These structures collectively are present at the porta hepatis. Okay. And blood supply of liver. Liver has a dual blood supply. The major source is the portal vein, which carries about 70 to 80% of the blood to the liver, and the rest is by the hepatic artery. Okay. Is this part clear to everyone? Yes or no? Okay. Now, the gallbladder. So, the liver forms the bile. The bile is collected and stored in the gallbladder. Okay. So, the gallbladder, the main function is, remember, gallbladder does not produce bile. It simply stores and concentrates the bile. So, bile is formed from liver. Liver is somewhere present like this, falciparum ligament, from left side, from right side. So, right and left hepatic ducts, they collect the bile from the right and left lobes of liver. The bile comes in this common hepatic duct, enters the gallbladder via cystic duct, and is stored here. The storage capacity is about 30 to 50 ml. When there is some stimulus for the gallbladder to release the bile, say, so the bile, the function of bile is to help in digestion of the fatty food. Bile emulsifies fat. So when you have taken a large fatty intake, deep fried items, lots of ghee or butter, so the gallbladder receives some stimulus. So the gallbladder contracts. Once the gallbladder contracts, the bile again comes out. So the next cystic duct into the common bile duct, goes into the duodenum, where it mixes with the ingested food and helps in the fat digestion. Blood supply of the gallbladder from cystic artery, which is a branch of the right hepatic artery. And the three parts of gallbladder, the fundus, the body, and the neck. And the neck, this part usually has a Hartmann's pouch, which is nothing but a fold of mucosa. And so you must remember the pathway of bile from the hepatic ducts to the common hepatic duct to gallbladder, then outside into the common bile duct to the duodenum. Blood supply, cystic artery. Now, there are two important triangles of surgical importance. Okay. So, majority of gallbladder surgery is nowadays done via laparoscopic route. Okay. So, when you are doing a laparoscopic cholecystectomy, there are a few important landmarks, important anatomical findings you must identify to perform a safe laparoscopic cholecystectomy. Okay. Because if you deviate from the standard teaching, if you find unclear anatomy, or if you do not put enough effort to identify the anatomy, then you might end up injuring surrounding structures, the most important and the most dangerous of which is the bile duct. A bile duct injury will lead to lifelong misery of both the patient and the surgeon. Okay? The patient will need repeated interventions. There may be stricture formation. biliary leakage, ERCPs, stentings, drainage, lots of things. He will never live in peace after that and will not let you live in peace also. So, identifying the anatomy is of crucial importance. And if you cannot identify, it is always safe to bail out. Either you abandon the procedure, refer the patient to someone who can do it, or you convert to open procedure. You do till as much as you feel is safe. Okay, you remove even a part of gallbladder, remove the stone, put a drain, and come out. Anyway, I was going more into surgical things. Now, see here. So the triangle of Callot is something which we must identify during a laparoscopic prostatectomy. The Callot's triangle is actually a part of a larger cystohepatic triangle. So the name suggests cystohepatic triangle. So the triangle that formed by inferior border of the liver, the gallbladder with cystic duct, and the common hepatic duct. Okay, cystohepatic triangle whose content is the cystic artery. Okay, and the Callot's triangle is a part of the cystohepatic triangle which is bounded by the cystic artery. This one, in the common hepatic duct and cystic duct. This contains the cystic lymph node. Okay. Are these two triangles clear? Please take the effort of responding yes or no. Right. So, two triangles, cystohepatic and Callot's triangle. Cystohepatic triangle, wait. Something is wrong with this cursor. Just a minute. Yeah. So, cystohepatic triangle, it is a triangle formed by the inferior margin of the liver, the common hepatic duct, and the gallbladder with cystic duct. This is the cystohepatic triangle whose content, as you can see, is this artery. This tiny artery you see here, this is a cystic artery. So content of cystohepatic triangle is the cystic artery, and the boundaries are the liver, the common hepatic duct, and the gallbladder with cystic duct. And the Callot's triangle, the triangle of Callot, is a subset of the larger cystohepatic triangle. It contains, it is bounded by the cystic artery itself, the common hepatic duct, and the cystic duct. The content of the Callot's triangle is the cystic lymph node. Is it clear now? Dr. Saroj, is it clear to you? Right. Continuing. So what is this? Yes, it's a caterpillar. So you all know why I'm showing this, because this is the famous Moynihan's caterpillar hump. This is what you see here. Okay. So I suppose you can appreciate the difference. difference between this anatomy and this anatomy. So you see here, this this red thing going behind the cystic artery. This is the right hepatic artery. A branch of it is coming here to the gallbladder, which is the cystic artery. This one. On the other hand, here you see this big artery is present where the cystic artery should have been. Okay, and this tiny artery is actually the cystic artery. So instead of the cystic artery being here, the right hepatic artery itself is present here, forming a hump-like formation like a caterpillar, which is known as the Moynihan's caterpillar hump. Which is nothing but an aberration of the right hepatic artery. Why is it important? It is important because if you don't identify it correctly, so instead of ligating the cystic artery, you might end up ligating the right hepatic artery, which may lead to some ischemic necrosis of the liver. Next, the pancreas. So the pancreas is a very interesting organ. It has dual functions, both exocrine and endocrine functions. Okay, exocrine because it has various enzymes, amylase, lipase, and so on and so forth, which help in carbohydrate digestion and fat digestion. And endocrine function because it secretes various hormones, insulin, glucagon, somatostatin, which has various role in the metabolism. So it's a dual organ. Parts, so 5 parts. The head, this part is the head. It lies in the C of the duodenum. Okay, head of pancreas. Then the neck, the Ansnet process is here. The neck is here. And then you have the body over here. And then the tail over here. Okay, so this tail, just here lies the spleen. Okay, and here lies the kidney. So there is a ligament, a fold of tissue between the spleen and the kidney. This is known as the lienorenal ligament. And the tail of pancreas lies within this ligament. Okay, but this is of importance. I will show you why. Just remember the tail of pancreas lies within the lienorenal ligament. And blood supply of pancreas. I don't know what's wrong with this student. Anyway, you see here. So the pancreas is supplied by sources from both the celiac trunk and the superior mesenteric artery. How? The celiac trunk gives the common hepatic artery, of which a branch is the gastroduodenal artery. The gastroduodenal artery gives the superior pancreatic duodenal arteries. Okay. And the superior mesenteric artery, it gives the inferior pancreatic duodenal artery and the splenic artery. So the head and neck region is supplied by both the superior and the inferior pancreatic duodenal arteries, which come from the celiac trunk and the SMA respectively. And the body and the tail supplied by the splenic artery, which is again by the celiac trunk. Okay. Now, how does this drain? So if you remember this diagram, the common bile duct comes from here. This is the common bile duct. The pancreatic duct comes from here, and together they join to form a dilated ampulla of Vater over here. And this common opening opens into the second part of the duodenum at the major duodenal papilla. And the opening is guarded by a sphincter of Oddi. Okay. Look at this diagram, you will understand more easily. So if you see the magnified portion of the second part of duodenum, this is the second part of duodenum from here to here, the D2 segment. If you remember, D2 has something known as the major duodenal papilla, above which there is the foregut, below which is the midgut, This is the division. So the major duodenal papilla is nothing but a bulging by this common duct, the ampulla of Vetter, which is formed by the confluence of the common bile duct and the pancreatic duct. Okay, so the common bile duct, the pancreatic duct, they together join, they form a dilated area known as the ampulla of Vetter, which bulges into the second part of duodenum, forms the major duodenal papilla. And this opening is guarded by a sphincter known as the sphincter of Oddi here. Clear so far? Right. Next, the spleen. So as I was saying, you have to remember that, see, this is the pancreas. Okay. The tail of pancreas lies within this ligament, the splenorenal ligament. Okay, so I'll come step by step. First of all, this is the stomach. This is the pancreas. This is the spleen. So there is one peritoneal hole between the stomach and the spleen, known as the gastrosplenic ligament. This one, the gastrosplenic ligament between the stomach and the spleen. Okay, this is posteriorly, this is anteriorly. So the stomach is here. So there's a fold of peritoneum between the stomach and the spleen, the gastrosplenic ligament. This one, the same one is here in a different view. So the gastrosplenic ligament, it contains the short gastric vessels. Okay, short gastric vessels. So whenever you are doing a splenectomy, you have to divide the gastrosplenic ligament with the short gastric vessels, and you have to divide the splenorenal ligament or the lienorenal ligament. Same thing. Okay, this contains the tail of pancreas, as you can see here, along with the splenic vessels. Splenic vessels, splenic artery, splenic vein, they come within the splenorenal ligament. So whenever you're doing a splenectomy, there is possibility that you might injure the tail of pancreas. So two important ligaments to remember: the gastrosplenic ligament containing the short gastric vessels and the splenorenal or the lienorenal, whatever you remember both because these are often used interchangeably. It contains the tail of pancreas plus the splenic vessels. Is this clear? Right. Okay. Then the kidneys. So the kidneys are retroperitoneal organs. Okay. Extend from T12 to L3. And the right kidney is located slightly lower than the left kidney because of the liver. The liver is above the right kidney. And layers of kidney, important question right from your undergraduate days. So from deep to superficial, inside outwards, first you have the renal capsule, this one, outermost layer, this one, okay. Then you have this layer, which is the perirenal fat. Peri means just adjacent to. Then you have this fascia, this thick line, this one. This is the renal fascia or the Gerota's fascia. Okay. This Gerota's fascia encases both the kidney and the adrenal gland, which is sitting over here. The suprarenal gland or the adrenal gland. Gerota's fascia encases both these organs. Then you have the pararenal fat. This one. So, capsule, then the perirenal fat, then the fascia, then the pararenal fat. Okay, the layers of kidney inside outwards. And how does the urine collect? it all forms in the nephrons. The nephrons drain into these pyramids. These are the pyramids. So from here, they collect into these minor calyces, these places. Okay. They coalesce to form the major calyces. They form this large renal pelvis from where the urine goes to the ureter. Okay. Let's supply of kidney, renal artery, renal vein. You must remember the origin at L1, L2 levels. And if you remember, we had discussed the drainage of the renal vein was little different from that of the right side. On the left side is different from the right side. How is it different? On the right side, the renal vein drains by itself into the IVC. The gonadal vein drains into the IVC by itself, and the adrenal vein drains by itself into the IVC. On the other side, on the left side, you have the left adrenal vein, you have the left gonadal vein, both of them draining into the left renal vein, which then goes into the IVC. Okay, this difference you must remember. And this is just for information. When the artery enters the kidney, it gives off five broad branches, five main branches, which collectively supply five parts of the kidney. Okay, these are known as the vascular segments of kidney. Why is it important? It is important because they are end arteries. So if this artery 1 gets injured, so this part will undergo ischemia. It will not receive circulation from the surrounding parts. Okay, these are vascular segments of the kidney. Previous slide. This one. Right. Okay. Now the development of kidney, it starts from the 5th week, and by 8th week, so the kidneys ascend. As you all recall, the testis descends, kidneys ascend. So it forms in the 5th week from this uteric bud and the metanephric blastema. And over the next 4 weeks, it ascends to the position we see in the adults. What is the problem with the horseshoe kidney? So the horseshoe kidney, as you see, the lower poles are fused. This should have been the ideal scenario like this, but here the lower pole is fused like this. Okay. So what happens? So you see the kidney is ascending from here to here to here. This is the IMA, the inferior mesenteric artery. It is a midline branch of the aorta. So if the kidney is ascending and the lower poles are fused like this, so the ascent of the horseshoe kidney will be halted by this midline structure, which is the IMA. Did you understand this? The lower poles are fused, and anything which is there in the middle will prevent the thing from going upward like this. Okay. So IMA starts from L3 level. So the fused lower poles will get stuck below the IMA at the L3 level. Did you understand this? Then the ureters, they are about 25 centimeters long. One important anatomical relation is that they run beneath the uterine artery, which is of importance during a hysterectomy. During hysterectomy, the surgeon, the um, gynecologist, they will clamp the uterine artery before they take out the uterus. While clamping, they have to be careful not to injure the ureter. And this is how it is classically described: water running under the bridge. Water being the urine in the ureter under the uterine artery. Okay. And the ureter is not a straight pipe like this. Okay. There are various constrictions, narrowings like this. So the first narrowing is at the ureteropelvic junction at the beginning. So just after it starts from the kidney as the pelvis and the beginning of the ureter. So at the PUJ, pelvic-ureteric junction, it is the first constriction. Then it descends more or less in a normal caliber. At this point, where the iliac vessels cross, it is again compressed. Okay. And finally, when it enters the bladder, at this point, on two sides, at the vesico-ureteric junction, VUJ. Vesica means the bladder. So the VUJ, where the ureters enter the bladder, that is the third narrowing, that is the narrowest part of the ureter. So why is this important? Because renal stones or ureteric stones can get stuck at these levels. Next, the urinary bladder. A few points about the bladder. First of all, the bladder wall has some irregularities known as the trabeculae. This photograph, as you can see, this one, this is an inside view of the bladder seen through cystoscopy. So when you put a cystoscope through the urethra, you enter the bladder. This is the normal wall of the bladder that you can see with these trabeculae. Sometimes it may so happen that the bladder tends to get distended a lot. In such a condition, where the bladder is overstretched, in those conditions, the trabeculae may disappear, showing that there is some chronic urinary retention in this patient. Okay. Say, for example, elderly man with an enlarged prostate. There can be two scenarios. One, suddenly one fine morning, the urine stops. He's unable to pass urine anymore. This is known as the acute retention. Okay, it's an emergency. He has to attend the casualty. He will need a catheterization to drain the urine. One more scenario can be that the prostate is enlarged and he is having difficulty to pass urine, but he is not completely obstructed. He is passing urine in a narrow stream, dribbling of urine. Some urine is passing, okay, but there is incomplete voiding, incomplete bladder evacuation. A significant amount of urine is being retained even after he passes urine, and that continues to accumulate. So, over time, gradually, the bladder capacity increases. The bladder gets used to holding more and more urine. So, in this scenario, in a chronic retention, when you put in a cystoscope, you may see that the trabeculae has disappeared. Next, another part is the trigone. Trigone is a triangular area. So, if you see this part, the two openings of the ureter and the opening of the urethra, this part is known as the trigone. Okay. So here, as you can see, this is the ureteric opening of the left side. Same will be somewhere around here over the right side, and this is for the urethra. So a triangle between these 3 points is known as the trigone. The trigone is naturally smooth walled. Okay. Next point, the bladder wall has a unique muscle known as the detrusor muscle. It's a specialized smooth muscle present in the wall of the urinary bladder, which when contracts leads to voiding, which when relaxed leads to storage of urine in the bladder. Then the urinary bladder has innervations, both autonomic and somatic. Autonomic by sympathetic and parasympathetic, When there is sympathetic stimulation, the bladder will hold urine. Sympathetic S for storage. Remember this. S for sympathetic, S for storage. By virtue of sympathetic stimulation, the bladder will store urine. The bladder wall will be relaxed, the sphincter will be closed. In case of parasympathetic stimulation, the bladder wall will contract, the sphincter will relax, and it will pass urine. This is the autonomic nervous system. But you definitely have some voluntary control as well, where you can control the external urethral sphincter. This control is provided to you by the pudendal nerve, root value being S2, S3, S4, which gives you the your own capacity to contract or relax the sphincter. Okay. Clear so far? Right. Trigone is a triangular area between the two ureteric orifices, as you can see here. This point, this will be from the right side. The ureter coming like this will open here. This is opening here, and the opening of the urethra, this point. So this, this is the trigone between the two openings of the ureter and the urethra. Okay. Then the male urethra is of particular importance. It's about 20 centimeters long, the female urethra being only 4 centimeters long. Now, this long urethra comes with its own uh, unique characteristics and problems. The urethra is divided into three parts. Inside outwards, this is the bladder. Okay, this is the bladder. The urethra starts from here. So, and this is the prostate. Prostate is organ sitting. So this is the urinary bladder, as you can see here. Urethra coming like this, and the prostate is organ sitting just at the neck of the bladder. So the urethra passing through the prostate is known as the prostatic urethra. Then there is a narrow, small part known as the membranous urethra. And then the urethra present within the penis is known as the penile urethra. The penile urethra is the longest part of the urethra. Membranous is the narrowest and the smallest part of the urethra. And the prostatic is the widest and the most dilatable part of the urethra. Why is this important? So whenever, say, as I said, a man might come with a urinary retention, prostatomegaly. You have attempted putting in a Foley's catheter. Now, the first point where the catheter will get stuck, might get stuck, is the membranous urethra. That is the narrowest part. Okay. So the Foley's catheter may get stuck there. Even if that part is negotiable, then because the patient has a prostatomegaly, the second part where you might get stuck is the prostatic urethra. Okay. So although the prostatic urethra is the most dilatable part, in case of prostatomegaly, that part might be compressed. Okay. So remember the length of urethra, the three parts, narrowest part being the membranous urethra. And the lymphatic drainage of the urethra is also divided in different parts. The penile urethra, this part drains into the superficial and the deep inguinal nodes, whereas the prostatic and the membranous urethra, they drain into the internal iliac lymph nodes. Okay. Then the prostate, so as I was saying, the prostate is a gland which is sitting at the neck of the bladder. Okay, so the urethra has to pass through the prostate, and the prostate is described in various zones. Earlier, we used to learn in various lobes of prostate. the anterior lobe, posterior lobe, lateral lobes, median lobe. Nowadays, the important concept is of the zones of prostate. Okay, McNeil described the prostatic zones, McNeil's zones of prostate. So this is the bladder, this is the urethra, this entire thing is the prostate. This entire thing is the prostate. Urethra passing through the prostate. So the zone of the prostatic tissue just around the urethra is known as the periurethral or the transitional zone. Okay. Then the zone at the periphery, this blue colored area, is known as the peripheral zone. This is important in cases of carcinoma. So when the prostatic tissue enlarges, grows in size, in case of malignancy, it is the peripheral zone which is primarily involved. And the common prostatic enlargement seen in elderly males is benign hyperplasia. This part grows when the central zone grows in size. Okay. And anteriorly, you have some hypermuscular stroma. So central zone grows leading to a benign hyperplasia, very common in elderly males. And the peripheral zone grows leading to a carcinoma. And there is the other one, transitional zone, periurethral zone. Lymph node. The penile urethra drains into the inguinal nodes, the two groups, and the rest of it in the internal iliac nodes. Okay. Anyone else? Any questions? Okay. Then the descent of testis. So the testis, they start development in the third month. Okay. In the second or third month. And with every subsequent month, it kind of goes further downwards. So the starting is in the second or third month. Then it reaches the deep ring. So if you remember when we had discussed about the inguinal canal, we had discussed that the testis develops within the abdomen and ultimately comes in the scrotum outside the abdomen. The pathway for this kind of a travel is the inguinal canal. Okay. So this is the wall of the abdomen, all these layers. Okay. So it is now inside the abdomen. Then it is coming at the opening in the abdominal wall, which is the deep ring at the 4th to 6th months. Then in the next month, it travels through the inguinal canal, coming to the superficial ring by the 8th month over here. Okay. Then by 9th month, it goes into the scrotum, usually just before or just after the time of delivery. Is this clear to everyone? Okay, the prostatic zone, someone asked. Yeah. Okay. So let me see if this works out. It's not working. I'll clear these markings and I'll tell you again. Okay. So this is the bladder. This yellow line is the urethra. This entire structure is the prostate, lying just at the neck of the bladder. Okay. And the prostate is divided into few zones based on their clinical relevance. In the front, there is just some fibromuscular stroma. The zone of the prostate, the area of prostatic tissue, which is surrounding the urethra, is known as the transitional zone or the periurethral zone. Okay. Now, the remaining part of the prostate is divided into a central zone and a peripheral zone. In case of a carcinoma, so the prostate will enlarge, be it a carcinoma, be it a benign hyperplasia. The patient will come with more or less similar symptoms because the prostate will enlarge ultimately, leading to compression of the urethra, leading to features of lower urinary tract symptoms, LUTS, like narrowing of stream, straining to pass urine, dribbling of urine, incomplete voiding of urine. So the prostatomegaly scenario will give rise to these kind of symptoms. Okay. Now the prostatomegaly may be because of a benign hyperplasia or the carcinoma. Why it is important to understand is that two different parts of the prostate enlarge in two different scenarios. The central zone enlarges in case of a benign hyperplasia. The peripheral zone enlarges in case of a carcinoma. This is important because the treatment differs, the surgical approach differs. So when there is just a benign hyperplasia, then you can do a cystoscopy, you pass a scope through the urethra, you reach the prostatic urethra, and you can just cut out the tissue surrounding the urethra, which is effectively the central zone of the prostate. Okay, to enlarge the narrowed tract, and patient will be able to void normally. But if it is a carcinoma, then a TURP, which is the transurethral resection of prostate. A TURP cannot be done in case of a carcinoma because in TURP you put a scope and resection device through the urethra, you cut out the central device, the zone. Whereas in the carcinoma, you have to take out the peripheral zone. So in this case, you have to do a radical prostatectomy. So understanding the zones is important because the pathology differs. Central zone enlargement leads to a benign hyperplasia. You can treat by a TURP. Peripheral zone enlargement leads to a carcinoma, which has to be done by a radical prostatectomy. So you have diagnosed a prostatic cancer by biopsy. But if you don't know which part of the zone is enlarged, you cannot do the accurate treatment. Is this clear or did I confuse you more? Wait, someone has asked something first. Let us sort out that. Okay. So Preeti, descent of testis options are 2, 3, 4, 6. So that is not actually a right question. The descent starts from the second month, continues till the ninth month. Okay. So they might ask you, where is the testis located in some particular month? That is a better question, but the descent of testis is a process. It doesn't happen in just one shot. Yes, you at least wait for 1 year. So if they just give you one, just ask you when does descent happen and they give you these 4 or 5 options, that is not the right question. As you can see, it is a process starting from the second month to the ninth month. So they should ask you, it can come like, where is the testis located in the sixth month or fifth month? You will know it is the deep ring because it's a process. At different times it is located in different sites. And yes, it ideally comes in the scrotum just before birth or just after birth. But immediately after birth, if you can't palpate the testis, you do not label it as an undescended testis. It may take up to 1 year for the testis to come down to scrotum. Okay. Next, something about the mesentery and the omentum, peritoneum. Yes, correct answer. What, Dr. Saroj? What is your question? You can't choose answer. That is the wrong question. So if they ask you the duration, there was some, you have used the word duration of descent. So that may be around 6 to 7 months. The entire process takes around 6 to 7 months. As you can see here in the timeline, from second to third month to 9 month, it takes about 6 months. The entire process takes about 6 months. But specifically, if you are asking which month the descent happens, that is the wrong answer. That is the wrong question. Yes, so you have to read the question carefully, whether they're asking the duration or specific month. Okay, it doesn't happen in a specific month, but it takes about 6 months. Are the two different questions clear to you? All right. Next, the peritoneum and the mesentery. So, the concept of intraperitoneal and the retroperitoneal organs. So, you think of this peritoneum like a balloon. Okay, this is a balloon. You are trying to put something like this in the balloon. You're pushing this into the balloon. So the balloon will become like this when you are pushing this thing inside. Right. If you push it further inside, the balloon will become like this. Okay. So this is the concept of a retroperitoneal organ. This is the concept of an intraperitoneal organ. As you can see in this diagram, this is a kidney on two sides. So kidney is just pushing the peritoneum a little bit. This is known as a retroperitoneal organ. This is lying behind the peritoneum. Same as this aorta, IVC, they are just pushing into the peritoneum a little bit. These are all retroperitoneal organs. However, things like the gut, the intestines, the stomach, they have come all the way inside and are almost completely surrounded by the peritoneum. So they are known as the intraperitoneal organs now. Okay. So the intraperitoneal organs, they are joined by this fold of peritoneum known as the mesentery, as you can see here. And these mesentery, it carries the blood supply from the aorta and its branches to the various intraperitoneal organs. Okay. Peritoneum, a balloon-like structure containing organs in different positions. It may be a retroperitoneal organ or an intraperitoneal organ. For intraperitoneal organ, this structure known as the mesentery, it carries the blood vessels, lymphatics, nerves, all these to these organs. Okay. And the concept of parietal peritoneum and the visceral peritoneum. So if you see this diagram, the part of the peritoneum covering the viscera is known as the visceral peritoneum. this part. And the part away is known as the parietal peritoneum. If you extrapolate this concept to this diagram, this is the person lying on his back. This is the posterior aspect. This is the anterior aspect. This is the anterior abdominal wall. The peritoneum adjacent to this anterior abdominal wall is known as the parietal peritoneum, and the peritoneal layer covering the viscera is known as the visceral peritoneum. In between the visceral and the parietal peritoneum, this space is the peritoneal cavity. It's a potential space. It is not a ballooned up space by itself, but this space is used when you're doing laparoscopic surgeries. This space is where blood collects. If there is some trauma leading to hemoperitoneum, if there is a hollow viscous perforation, this area will contain the gas, the bowel contents, all these things. So the peritoneal space is a potential space which can be used to our advantage or may lead to various conditions. The parietal and visceral peritoneum, the mesentery. Is this idea clear to everyone? The concept of mesentery and the peritoneum? Yes or no? Which part? Okay. You see, all the abdominal viscera organs, they need to have blood supply, and the blood will come from the aorta and will go into the IVC by some branches or tributaries. So if the organ is lying here, deep inside the peritoneum, and the source of the blood is aorta is right here, so the branches have to go through something to reach the organ. This something is these two folds of the peritoneum through which the vessels and the lymphatics and the nerves go to the organs. So this something, this fold of peritoneum is known as the mesentery. Mesentery is named in different ways depending on which part of the gut it is supplying. Okay. So if it is supplying the small bowel, it is known as the mesentery. The mesentery of the colon is known as the mesocolon, right mesocolon, transverse mesocolon, left mesocolon, mesosigmoid, mesorectum. Okay. So mesentery is just two folds of peritoneum which contain lots of fatty tissue and the blood vessels and lymphatics to and from the gut. Understood? I'm seeing only two or three names responding. I hope others are understanding. I hope you are all awake. These are important things. Do not take these lightly. These are very vast topics which I am trying to concise for you. So please pay attention. And finally, something known as the epiploid foramen. Okay. This is a difficult concept to understand. What you must remember are the boundaries of the epiploic foramen. Okay. This is a kind of space of the peritoneum behind the stomach. And the epiploic foramen is the gateway to that space. It is bounded. If this is the foramen, as you can see, above is liver, the caudate lobe of liver, this one. Below is the duodenum. This is the first part of duodenum inferiorly. Posteriorly, here is the vena cava, IVC. And anteriorly, it is open. Here lies this free margin of the omentum, lesser omentum, the hepatoduodenal ligament. This one containing the hepatic artery, bile duct, and the portal vein. Okay. So this free margin of lesser omentum, also known as the hepatoduodenal ligament, is an important structure. And you must remember the contents: the hepatic artery, bile duct, and portal vein. Okay. Cephaloic foramen bounded superiorly by the liver, this part, inferiorly by the duodenum, this part. Behind there is the IVC, and front is opening and flanked by the hepatoduodenal ligament containing these three important structures. This structure is important because of, again, a surgical relevance. In case of trauma, suppose the liver is injured. Liver is a highly vascular organ and it can bleed profusely. So once you have opened up the abdomen, you are seeing the liver is injured, lots of blood, and you cannot exactly see from where the blood is coming. So you have to stop the blood supply to the liver somehow. So what you do is known as the Pringles maneuver. Spelling is wrong. Pringles maneuver. So you just hold this fold of tissue, this hepatoduodenal ligament, between your fingers. Just hold and clamp it. So it will effectively occlude all the blood supply to the liver. This is obviously not a treatment, not a final step. It's just a temporary step to give you some time to suck out the blood and to see from where the injury is happening, from where the blood is coming. So Pringles maneuver, you put a clamp, you hold the hepatoduodenal ligament, which will stop the blood supply to liver, and this ligament contains these important structures. So you cannot injure these structures, you cannot injure the portal vein, the bile duct, but you can temporarily occlude them to prevent bleeding from the liver and to see the site of injury, to repair the site of injury, and then restore the circulation. Understood? Yes or no? Okay. Those who are sleeping, please wake up because I'll be asking questions soon. And if I only see these names again, I'll call you individually and ask you questions. And finally, something is commonly asked, the structures passing across the root of mesentery. So, as I was saying, this is the mesentery of the small intestine. The root is like where they start. Okay, this part starts from the duodenojejunal junction and goes towards the ileocecal junction. Okay. Now, question which is commonly asked is, what are the structures crossed by the root of mesentery? Means structures lying behind the root of mesentery. This is the DJ flexure. This is the ileocecal junction. This is the root of mesentery. Behind this root of mesentery, there are various structures. Okay. What are they? First is the D3, the horizontal part of duodenum. Then you have the aorta, the IVC, the right gonadal vessels, right ureter, and the right psoas major. Okay. These three right-sided structures, right psoas, right ureter, right gonadal vessels, aorta and IVC, and the D3. Simple to remember. Do not forget this. Next, the pelvic floor. This is a very complicated area. I'll try to simplify it as far as possible for you. I hope the concept of mesentery is clear to you. Mesentery is just this folds of peritoneum containing fat and vessels supplying the bowel. The root of mesentery is something. Okay, so the root of mesentery is where the mesentery starts. Basically, it has to start from somewhere, from the posterior abdominal wall. Then it fans out like this and supplies the gut. So there are a few important structures which are behind the root of mesentery. This is important because these structures may come when you are operating. So you have to be careful that you do not disturb these structures, you do not injure these structures. The structures are the third part of duodenum, the aorta and the IVC, the right gonadal, right ureter, and the right psoas major. These structures lie behind the mesentery. So when you're operating, you are cutting the mesentery, you are removing the mesentery, you are uh, removing part of the bowel. So you will encounter these structures. So you have to know what lies where so as to you avoid those areas. Or once you say, you know, okay, this is here, I'll avoid this area. So see, basically entire anatomy is for you to apply it somewhere else. Anatomy knowledge by itself will not help you in any way. It is to be applied in clinical scenarios. Mostly it is a surgical scenario. Understood? Okay. Next, the pelvic floor. So, if you see a schematic diagram of the abdomen, this is the costal margin, this is the flank, these are the inguinal ligaments, these are the symphysis pubis. So, the abdomen is confined in this area. Then the lower limbs start. But there are organs which are present in this area. Okay, this is the pelvis. So this is the abdomen per se, and this is the pelvis. Now the pelvis has to have a floor to hold all the organs from up. It has to have the bladder, the females, the uterus, then the rectum. So all those have to be supported by a floor. They can just hang in the abdomen. Okay, and also it has to have some openings for all of the structures. There has to be opening for the urethra, there has to be opening for the vagina, there has to be opening for the rectum as well. So this is the view you are seeing. So the person is lying with his or her head towards you, the foot on that side, away from you. This is anterior, this is the back side, and you are seeing from the person's head end. So this is the cavity, the pelvic cavity, the two hip bones on each side, the iliac bones, the sacrum. This is the symphysis pubis. So this is the top view from the head end. The person is lying. These muscles, they combine the pelvic floor, and these apertures are for the various structures to pass, namely the bladder, the urethra, the rectum, and the vagina in females. Similarly, you see here the schematic diagram. The view remains the same. You have the sacrum over here, the pubis over here, the iliac bones on each side. This is the anterior part. This is the posterior aspect. So here these muscles are labeled. Okay. So the pelvic floor is broadly formed by two main muscles. One is the levator ani, one is the coccygeus. Now the levator ani is actually a group of three muscles: puborectalis, pubococcygeus, and the iliococcygeus. These three muscles together form the levator ani, which forms the most important component of the pelvic floor. Okay. So these fibers, puborectalis, pubococcygeus, and the iliococcygeus, they form the levator ani with some sphincter muscles surrounding these parts, and behind you have the coccygeus. from the sacrum to the iliac bones. So together they form a support of the pelvis. So here you remember the parts of levator ani. Then the perineum. So now you are seeing from the foot end. Okay. The person is lying, you are seeing from the foot end. This is again the anterior, the pubis. This is the tip of coccyx. The person's foot, legs are towards you. The head is off that side. You are seeing the perineum, which is the region between the two thighs, the floor of the trunk, the torso. So anterior point you have the pubis symphysis. Posterior point you have the tip of coccyx. Laterally you have the ischial tubercles. And you have a line joining these 2 points leading to a triangle in front and a triangle behind. The triangle in front is known as the urogenital triangle. The triangle behind is known as the anal triangle. The names, because of obvious reasons, anteriorly you have the genitourinary apertures. Posteriorly you have the anal apertures. Aperture. Okay. So together the perineum is described as a diamond-shaped area which is formed of two triangles, the urogenital triangle and the anal triangle. Okay. And the roof of the perineum is the pelvic floor, which we have just seen, and the base is the skin and the fascia. So if you see from outside inwards, first you see the skin, then you have this space, the perineal space, which you will see, and the roof is by the pelvic floor, and then comes the abdominal cavity. You see this diagram here. Okay, so this is a sagittal section. The person is cut from here, like this, in this plane, front of the body. So this is the pelvic cavity. This is the abdominal cavity. So this is the pelvic floor. These are the levator ani muscles. Okay. This part is the perineum from here. Okay. So the perianal skin and the levator ani muscle. In between this space is the perineal space. The perineal space has various subparts of clinical importance. What you see here is the ischioanal fossa. This is the area of importance because it is a very common site of development of abscesses. Every other day we get patients with a perianal abscess or a ischioanal abscess. What is that? That is an abscess, collection of pus in this space bounded by rectum, the anal canal on one side, the levator ani above and medially, the perineal skin at the floor, and laterally you have the Alcock's canal, which is important structure for passing the pudendal nerves and vessels. Okay, this is important. So here you'll be asked: ischianal fossa bounded by above by the pelvic floor, the levator ani muscles, medially by the anal canal. Then there's a floor, the skin of the perineum, and laterally you have the Alcock's canal transmitting the pudendal vessels. Okay. Now, again, in the sagittal section, you are seeing the perineum. So, this is inside the abdomen. These are the bones, the iliac bones. This is the levator ani muscle. Okay. Levator ani muscles coming like this. This is outside the body. The skin is over here. This is inside. So, between the skin and the levator ani, there are various spaces of the perineum, the various perineal pouches and their boundaries. So this purple area you can see here, this is the deep perineal pouch, this space. And this white area is the superficial perineal pouch. Okay, what are the boundaries? So if you go from outside inwards, so first you have this superficial perineal fascia, and you have the deep perineal fascia, the blue and the green. In between, you have the superficial perineal pouch. Okay, then you have the something known as the perineal membrane. This red line, if you can see here, this red line, this red line, perineal membrane. Above the perineal membrane, you have the deep perineal pouch. So two perineal pouches, deep and superficial, a deep line between liver planae above and the perineal membrane below, and the superficial pouch between the deep and the superficial perineal fascia. Just like we read in the layers of the scrotum, parts of the abdominal wall come and form the scrotal wall. So external oblique forms the external spermatic fascia. The internal oblique forms the cremasteric muscle and the fascia. The the fascia, the transversalis muscle forms the internal uh, spermatic fascia. In the same way, the fascia of the abdominal wall forms these superficial and the deep perineal fascia. So if you remember, in the abdominal wall, we had the outer Camper's fascia, the inner Scarpa's fascia. So the superficial perineal fascia is a continuation of the Camper's fascia. The deep perineal fascia is a continuation of the Scarpa's fascia, which is also known as the Colles fascia. Okay, are you with me so far? Yes or no? Colles fascia is the other name for the deep perineal fascia, which is a continuation of the Scarpa's fascia from the abdominal wall. Which part to be repeated, Dr. Saroj? The superficial and the deep perineal fascia, they are continuations of the fascia from the anterior abdominal wall. If you recall, there is the fascia of Camper and the fascia of Scarpa in the abdominal wall. So those are continued in the perineum as well. The fascia of Camper is forming the superficial perineal fascia. The fascia of Scarpa is forming the deep perineal fascia, and the deep perineal fascia, other name is Colles fascia. All right. Then you must remember the various important contents in these perineal pouches. So the deep perineal pouch, it contains the external urethral sphincter, the bulbourethral glands, and the deep transverse perineal muscles. Okay. And the superficial perineal pouch, it contains the some important muscles, the ischiocavernosus, bulbus conjugatus. Important is the Bartholin's gland. So these have can be asked. Bulbourethral glands in the deep pouch, Bartholin's glands in the superficial pouch. Okay. And finally, just to sum it all up, there's important body called the perineal body in the middle of the perineum, in between these two triangles, as you can see, the urogenital triangle, the anal triangle. Here you have the perineal body, the site of insertion of various important muscles. Okay. I didn't get that. What are you trying to say? What's the name of Colles fascia? Superficial fascia? Okay. Okay, so what I remember is it is the deep fascia, but okay, I'll look into it. All right, if you say so, I'll look into it. Okay. Any other feedback? Anyone? All right, I'll look into it. Okay, so let's start with the questions. I would like all of you to participate, please. Yes, so it is a branch of the internal iliac artery. The transpyloric plane, we had read in the last class, passes through. Yeah. The caterpillar hump, we had just seen, it is the anomaly of the. Yeah. So it's a hepatic artery. Cystic artery, it is present where the cystic artery is expected. It's actually a variation of the hepatic artery, the right hepatic artery. The nerve supply of the cremasteric muscle is. Yes, B. True for IVC. Yeah, so someone answered C. C. The IVC and the aorta pass through two different openings of the diaphragm. Okay. But that doesn't mean they are different, one lies anterior to the other. They lie side by side. The apertures, the levels of the apertures are different at two different levels, but they don't lie one in front, one in back. Okay, so the answer is B. Portal vein. Yes, others. Okay, so let us recall some things about the portal vein. How is the portal vein formed? It is formed by union of the splenic vein and the superior mesenteric vein. Inferior mesenteric vein is a tributary of the splenic vein. This drains into the splenic vein. Then the splenic vein and the SMV forms the portal vein. Okay, it lies directly anterior to aorta. We'll get back to this. It lies in the free edge of lesser omentum. So this we have just read in the hepatoduodenal ligament. It lies in front of the hepatic artery, the porta hepatis. So if you remember that diagram of porta hepatis, so this was the porta hepatis. At the very back was the portal vein. Then on the in the front, in the right side, you have the bile duct, and on the left side, you have the hepatic artery. Okay, this one. Is it clear? So as I had said, read the question very carefully. Splenic vein and IMV, they don't form the portal vein. The IMV drains into the splenic vein. Then the splenic vein plus the superior mesenteric vein, they form the portal vein. Okay. Okay. So what is the normal location of the major duodenal papilla? Okay, so the superior part is the D1. The duodenum is like this. The stomach comes like this. This is D1. This is D2. This is D3. This is D4. D1, D2, D3, D4. The papilla comes here in the second part, which is the descending part of duodenum. Okay. So which of the following is present in the deep perineal pouch? Yes, it's the bulbourethral gland. Which structure accompanies the esophagus through its hiatus? So think of the various structures passing through the various hiatus. We had something through T8 at something at T8 level, something at T10 level, something at T12 level. What were those? At T8 we had the vena cava along with the phrenic nerves. At T10 we had the esophagus along with the vagus nerve, and at T12 we had the aorta with the thoracic duct and the azygos vein. So esophagus will be accompanied by the vagus nerve. What anatomical structure is just anterior to origin of the portal vein? Yes, so the portal vein is formed just behind the neck of pancreas. No, IVC can't be anterior to anything. IVC is the most posterior structure in the abdominal cavity. Answer is T, neck of pancreas. So a man undergoes a diagnostic laparoscopy at the beginning of a prostatectomy. He is found to have a patent processus vaginalis. Which of the following is he predisposed to? Any other answers? Yes, so obviously it's B. Testicular torsion has nothing to do with this, and we have never discussed anything about torsion. A 42-year-old man stabbed in the right upper quadrant. What question of Saroj? If you have recalled the discussion on inguinal hernia, then you will remember we discussed this. Go back to your notes and see we had discussed something called the processus vaginalis. This was something which accompanied the testis during its descent for the dragging of the peritoneal cavity or peritoneal sac. So, peritoneal sac in the scrotum will obviously lead to a hernia, not torsion. Was that clear? Next. A 42-year-old man stabbed in the right upper quadrant. He is taken for laparotomy. The surgeon clamps the free edge of the lesser momentum in order to achieve rapid hemostasis. So, which artery has been occluded? We have been discussing this in the Pringles maneuver. This is exactly what is known as the Pringles maneuver, clamping the free edge of lesser momentum. Which artery are you occluding? So, those who are answering B, just think before you answer, okay? This is a stab injury in the right upper quadrant, meaning the liver is injured most probably. The person has been taken for laparotomy. There is bleeding, and you have clamped the lesser omentum to achieve rapid hemostasis. So, how will blocking the cystic artery help in this? The cystic artery is a very small artery supplying just the gallbladder. That's of no importance here. You have to stop the blood flow to the liver, okay? And the artery in the free edge of lesser omentum is the hepatic artery. Did you understand? All right. A 23-year-old man presents with severe perianal swelling and discomfort. MR imaging is done of its pelvis, which shows a abscess in the ischial fossa. So, which muscle lies superior and medial to this abscess? We discussed this. Yes, so it's a liver drainage. Remember this diagram? So this was the fossa, liver drainage muscle above and medially. So SMA arises from which level? Very common, very straightforward question. Do not miss out questions of this type. So the celiac trunk from the T12 level, SMA from L1 level, IMF L3 level, and they bifurcate at L4 level. During a laparoscopic inguinal hernia repair, you correctly identify a direct hernia with a sac protruding through Hasselback's triangle. What is the medial border of this triangle? Yes, guys, come on. Last class, hernia. Yes, so of these options, what is the answer? What is the other name for lateral border of rectus abdominis? That is linea semilunaris. Okay. So remember this diagram. Here you had this deep ring. Here you have the inferior epigastric vessels on the lateral side of the Silvax triangle. This is the lateral border of the rectus, the linea semilunaris, which is the medial border, and inguinal ligament forms the inferior border. So this is the Silvax triangle bounded by the linea semilunaris on the medial side, the inferior epigastric vessels on the lateral side, inguinal ligament on the inferior aspect. This is the site for direct hernias. And lateral to the inferior gastric vessels, you will have the deep ring with the indirect hernias. This is clear? Yes or no? Yeah. So previous slide. Yes. What is the question? Diti Singh, what are you asking? I'm not understanding. You asked for a previous slide, no? All right. Okay. So in a normal ureter, the diameter of its lumen narrows at, we have discussed the uretery constrictions, so recall them. Yeah, the answer is all of the above. Okay. We discussed this diagram today only, where from the kidneys it is starting. This is the pelvic ureteric junction where there is one narrowing. Then somewhere the iliac vessels they cross, that is one narrowing. And when they enter the bladder, that is the third narrowing. Okay. So one, two, and three over here. I didn't understand why some people mentioned the PUJ. Even if you misunderstood the question as the narrowest lumen, still that would be B. PUJ is just a narrow, it is not the narrowest part also. Okay. So if they ask you the narrowest part, it is the vesico-ureteric junction. And otherwise, these are the 3 points of constriction. A 79-year-old male presents with difficulty in passing urine and is diagnosed with a prostatic adenocarcinoma. From which histological structure is his disease most likely to have originated? So you recall the various zones we have discussed. Yeah. So answer is the peripheral zone. Which vessels are present in a line or in a ligament? We have discussed this in spleen. Yes. This is the splenic vessel. An adjunct of this question, what other structure is present in this ligament? Tell me. Yeah. So tail of pancreas. Good. A 46-year-old male, acutely painful left groin. He is tender over the area, and you notice that his swelling originates inferior and lateral to pubic tubercle. What is the most likely diagnosis? No one else? Hello guys, wake up if you're there. Yeah, so the answer is it's a femoral hernia. You see, look at this diagram. This is important, okay? This is the pubic tubercle, inguinal ligament. So hernias above and medial are inguinal hernias. Below and lateral are femoral hernias. Remember this diagram. Okay. All right. So that's all for today's class. Anyone has any questions? We can take them up. I'll get back to you on the college fascia thing. I'll just look into it. I might be wrong. Any other doubts? Any other feedbacks? All right then. Bye. Take care. Enjoy the holidays, I suppose.